Hey, good evening, everyone. Welcome back to the Academy for Addiction Professionals webinar. I'm Ben Braffman, the founder of the Academy. I appreciate everybody being here this evening. We're going to talk about tonight. I thought we would talk about the history of mental health treatment in America. Provided a PowerPoint for everyone. So we'll jump right into it. I felt it was a relevant topic, given all the momentum that mental health seems to have here in the United States. So we'll jump right into it. Ask a lot of questions. Look forward to the Q&A at the end. So the learning objectives tonight for this webinar. Identify the key historical events which led to the growth of asylums in the United States. I may use words like alienist, which is what they used to call psychologists back in the 17 and 1800s. So you may hear that word, and that means that mentally ill people were aliens. Describe how the field of psychiatry and clinical psychology grew and changed over the past 300 years. And then select 4 factors which led to the eventual closure of asylums and the present day focus on community care or continuity of care. So those are the learning objectives tonight. Give you a little bit of history and a little bit of sense of how far we've come with mental health treatment. So with mental health treatment, and as it relates to asylums, you have to think about 2 extremes. The history of the care and treatment of the mentally ill represents an endless journey between 2 extremes. So the one side of it, if you think about a spectrum, right? So on one side you have confinement in a mental hospital, which the conditions were inhuman, and then living in the community. And so those are 2 extremes. There's a lot to do to connect those dots to get a mentally ill person to be able to live in a functional manner in a community when they leave the hospital. But these are the extremes that the mental health industry was facing. 3 primary procedures when it comes to asylums. One is bleeding or cutting, vomiting, and purging. These treatments were non-specific and applied to all that ails you. So the idea is that if you had a mental illness, you were spiritually bankrupt, or somewhat of an exorcism needed to take place, that somehow your brain was diseased, and if they could either cut it out of you or somehow get it out of you, that you could be cured. Again, they were not specific because there really wasn't a lot of research done. And these quacks, they came up with this barbarian approach to treating the mentally ill because you can't see a broken brain. So they had to apply some sort of logic to it. And it really doesn't make a heck of a lot of sense now, especially with all that we do. So the primary procedures, they long outlived the theories that justified them, even into the 19th century. So, I mean, in terms of time, not too long ago, were they cutting people and forcing them to vomit and purging, and it just really despicable behavior. Even once realized to be invalid scientifically, doctors would sometimes use these approaches. In the 17th century, as you can see, society is more rural and agricultural. Communities are small and scattered. Mental illness is an individual, not societal problem to be handled by the family and not the state. So you can imagine that it really wasn't handled. Families really struggled with mental illness, thinking that somebody was faking it, or they were so embarrassed that they had to, you know, tuck that person away somewhere. And sometimes that meant putting them into an asylum. Concepts of insanity are fluid and not medical, arising from more from culture, popular, and intellectual theories. And then, you know, the Monty Python's village idiot concept that, you know, mentally ill people are stupid or retarded, or there's just, you know, something wrong with them, so they need to be treated differently. 18th century American colonialism, institutionalization first appears by the early 1700s, based upon the English principle that society had a corporate responsibility to the poor and the dependent, largely precipitated by demographic shifts and industrialization, leading to population increases in cities and a relative increase in the proportion of sick and dependent persons. So, you know, the bigger the cities got, you know, you had pockets of poverty and people not being able to take care of themselves or not access to medical care. Geographic mobility leads to less neighborhood cohesion, a lot of isolation. Medical considerations were minimal. The real issues were economic and public safety. Undifferentiated welfare institutions and almhouses treated the aged, infirm, very young, and mentally ill. And you can imagine these places were not suited to treat that variety of population. Hospitals. A recent invention created by affluent trustees for the less fortunate, not for themselves. As late as 1873, there were only 178 hospitals in the US, a third of which were for the mentally ill, with a total of fewer than 50,000 beds. Currently, on the order of 15,000 hospitals in the US and approximately 1.8 million beds, just to show you the difference. Moral treatment. Pre-industrial people tended to accept their fate. 18th century Enlightenment stressed innovation and problem solving by conscious and purposeful human intervention. Penal created moral treatment, which suggested that environmental changes could affect an individual's psychology and thereby change his or her behavior. So people with severe mental illness were taken out of their family unit. They were put into hospitals, or they were isolated, thinking that that would cure them, which of course we know that that's not the case. The birth of the asylum. Pinel rejected the prevailing belief that madness was incurable, and he suggested that confinement in a well-ordered asylum was indispensable. And then Benjamin Rush, who also was one of the pioneers in creating the school system that we know of in the United States. And then William Tuke was also instrumental in creating part of the asylums and part of the structure of it. Asylums, late 1700s and early 1800s. Bedlam, Bethlehem Hospital was established in the 13th century, but was a storage facility. Well-established American asylums included McLean in Boston, Bloomingdale in New York City, Butler, Pennsylvania Hospital, and the Hartford Retreat. These were set up for wealthy families who would not mix with racial and ethnic minorities, for whom these insane asylums remained the only place. In 1844, the Association of Medical Superintendents of American Institutions for the Insane was founded. Coincidence with the emergence of psychiatry, the second subspecialty after surgery. Later to become the American Psychiatric Association, the APA, the first medical specialty organization in the nation. Founded by the American Journal of Insanity. There's a copy. It actually did exist. You can actually get these. Just read it for a second. The American Journal of Insanity, the officers of the New York of New York State, the lunatic asylum in Utica. Public asylums. By the 1820s, it became clear that the wealthy asylums could not care for the poor, who were overwhelming the insane asylums and urban streets, the almhouses. During the second half of the 19th century, the responsibility for the insane slowly fell under the jurisdiction of state asylums. This movement went on for about 100 years. When asylum populations hit their peak in 1955, roughly 600,000 patients at that time. 100 years of mistreatment. The massive growth of asylums was more of an accident than a proper plan. Psychiatry and asylums. Asylums predated psychiatry, not vice versa. So can you imagine that these people were put into these asylums thinking that they're going to get care from a doctor who specializes in insanity or mental illness, and actually that was not the case. You had doctors really winging it and trying, as I mentioned earlier, cutting people open, making them vomit. There were some doctors, and I may talk about this a little bit later, they used to remove parts of your organs. Many times that your teeth were removed, thinking that that was part of what was causing the mental illness. There was a lot of things that went on, like hydrotherapy, where they're putting people underwater, and the dental stuff that I just mentioned about pulling people's teeth out, or the lobotomies, which are often spoken about. Somehow this made sense to people. Somehow cutting out a piece of your brain, or removing your teeth, or exorcisms that made sense. A symbiotic relationship between asylums and psychiatrists developed, each conferring legitimacy upon the other. Psychiatry worked hard to establish itself as the proper leader of asylums. Medicine was an unstable career. There were lots of non-allopathic healers who challenged the primacy of MDs. So a lot of potions, a lot of magic men, a lot of charlatans claiming that they could cure everybody's mental illness or ailments. Moral treatment in asylums. Insanity was due to two causes: lesions in the brain, or number two, moral causes. So if you were immoral to some degree, you were insane, or you had cancer of the brain. Moral insanity was due to willful violation of natural laws that govern human behavior, such that immorality, improper living conditions, and stressors could precipitate illness. Because physical causes could not be addressed, treatment focused on the moral causes: masturbation, alcohol abuse, excessive ambition, jealousy, and pride. Treatment was a synthesis of medicines, religion, and morality. So there was a combination of all these things, thinking that it can rid the body of the mental illness. Somehow it was a bacteria or a virus. Heroic treatments were still used, but unjustified. Psychiatric Job Security, 1830s to 1900. Asylum physicians had a good gig going because they were really getting ramped up, and they basically had a clean canvas for from what to work from. Nobody was going to tell them that they were wrong because there really wasn't any literature on it. They were influential, enjoyed a well-paid job, and had high status in medicine. Little interest in joining the AMA upon its founding in 1847. The Reality of Asylum Life, the late 1800s. Asylum life was rapidly becoming a real mess, and by the close of the century, asylum legitimacy was being questioned. Moral treatment demanded small settings, but patient numbers kept increasing. Psychiatry became largely managerial and administrative. Decreases in infant morality meant more dependent elderly, only some of whom were senile. Mental hospitals became surrogate old age homes. So they were overpopulated. The conditions were just completely awful. You can see here that repositories for those with tritary syphilis morality rates in asylums were 5 times the general population due to overcrowding. Just the conditions were just brutal. It was worse than being a prisoner. You didn't get food. The bathroom conditions were out of control. The staff was abusive, and the doctors weren't present. Germ Theory. You guys are going to like this one. General medicine now becomes legitimate and powerful. Psychiatrists scramble to identify new careers outside of institutions, articulating novel treatments and theories. A preventative role is seen in following upon Freudian theory. Neurosis and stress become legitimate illnesses worth treating. Neurology tries to discredit psychiatry. So a lot of infighting. The AMSAII changes its name to the American Medico-Psychological Association, or AMPA, to reflect its desired focus as a more medical specialty and to disassociate itself from institutions. Dynamic psychiatry viewed psychic distress along a continuum from normal to abnormal. Treatment focus shifted away from asylums and towards psychiatric institutes and hospitals. Pathological Institute established in New York City in 1895. The appearance of the psychiatric hospital, the missionary evaluation, treatment, and referral, Bellevue, the child unit, adolescent unit. So just so you know, there is a difference between an insane asylum or an asylum and a psychiatric hospital. So as you can see, like, we were ramping up to what we know today as a psychiatric hospital, but still the conditions were extremely poor, and people weren't getting the treatment that they deserved or needed. Psychopathy. Psychiatry stretched beyond psychopathology to include conduct and other behavioral disorders within its domain, sexual behavior and criminality. This occurs partially because of genuine concern and interest, and partly because of the desire to move somewhat away from the chronic and persistently mentally ill who are housed in asylums. Striving for legitimacy. The AMPA becomes the APA in 1921. The Journal of Insanity becomes the American Journal of Psychiatry. It's a good trivia question for all you history buffs out there. Psychiatry is unable to gain a foothold in universities before World War II. The first professional board, the American Board of Psychiatry and Neurology, is founded in 1934 and provides for board certification. So you can see it's getting more and more legitimate. Home care. In an effort to decrease costs to the states, home care becomes an option in the 1920s and 30s. Families either couldn't or wouldn't manage their sick relatives at home. Meanwhile, overcrowding continues at asylums, and there is less and less money available to take care of the infrastructure. New somatic treatments, all from Europe in the 1920s and 30s, quickly adopted in the US because of the great desire to treat the ill, received with great optimism. The states were spending lots of money on custodial care. Psychiatry was anxious to legitimize itself as a true medical specialty. Regardless of their true utility, these somatic therapies breathe great hope into American psychiatry on the eve of World War II. Fever therapy. Jules Wagner Jareng, University of Vienna, based upon the observation that mental symptoms occasionally disappeared in mental patients ill with typhoid fever. He injected malarial blood into mentally ill patients, aka malarial therapy. Received the Nobel Prize in 1927. Used commonly with syphilitis in the US. No evidence of its utility. Diabetic coma. Manfred Sakel, Vienna's physician, based upon his observation that diabetic drug addicts treated with insulin in 1928 had decreased in psychotic symptoms. By the mid-1930s, he was routinely using this treatment in psychotic illnesses. The hypoglycemic state resulted in a coma relieved by administration of sugar. Lacked a rationale theory and it didn't work. So you see all these are all these new theories that were coming out post-World War I, pre-World War II. Metrazol treatment. Ladislav von Muden, Hungarian physician, based upon the observations that epileptics are rarely schizophrenic. He employed metrazol to induce convulsions. He postulated a biological antagonism between the two illnesses. Little data was collected. The problems with shock. Many potential side effects to insulin and metrazol. Insulin comas were sometimes fatal and could induce seizures, pulmonary edema, and respiratory distress. Metrazol was safer, but could lead to fractures and respiratory distress. Still, these treatments became quickly in vogue and were to be found in every asylum and psychiatric hospital by 1940. And then came the introduction of electroshock, a safer alternative to Metrazol, developed by Ugo Cerletti, an Italian physician who believed in shock treatment, but found insulin and Metrazol too dangerous. Was shown to work effectively, particularly with affect disorders and psychotic mood states. So affect disorders, depression, anxiety, even bipolar disorder, psychotic mood states could be mania, schizophrenia. The problem was that psychiatric nosology was so shoddy, as were diagnoses themselves, that it was hard to apply this treatment to the right patient. Lobotomy. Agas Mons of Portugal, developed by Moniz in 1935. It was a runaway hit with US physicians. This treatment had a firmer theoretical justification than the shock therapies. A simple surgical procedure that involves severing the nerve fibers of the frontal lobe. Between 1936 and 1951, at least 19,000 lobotomies were performed in the US. You got to wonder how many of those 19,000 didn't need the lobotomy at all. World War II. After 1945, there became a great emphasis upon shifting care away from hospitals and into the community. The war had influenced psychiatrists. They saw the impact of environmental stress, shell shock. They saw that non-institutional treatment could be beneficial. They saw how pervasive these illnesses were. That is, the breadth of psychiatric illnesses became more evident, not just the severe and persistent illnesses. Psychoanalytic theory. By the end of World War II, the APA became more psychodynamic and analytical. These same leaders took control of university departments of psychiatry. There became a contrast between psychiatrists focused on institutional patients with severe illness of presumed biological etiology and those focused on psychodynamic and community-focused treatment. Post-war changes in healthcare. After 1945, the nation's healthcare system underwent major changes as a result of federal initiatives, the development of third-party insurance, a commitment to medical technology and specialization. The NIMH was established, and so ended a long period of federal passivity in mental health policy. Community mental health centers were established in every state during the 50s on the theories of prevention, early identification and treatment, following a psychodynamic model, follow-up care for institutionalized and hospital patients. State contributions outpaced federal allocations because of their optimism and potential financial savings. Psychology. An historically philosophical field that became experimental in the late 1800s in Germany. Following upon the work of Watson and Skinner, claimed to have amassed much data by the 1940s, having derived explanatory theories relevant to normal and abnormal behavior. Psychiatrists had little evidence to support their treatments and were generally not well trained in research methods. All parties concluded research must be multidisciplinary, and the NIMH began to support both fields in research and clinical training. The Milieu Therapy, 1950s, AKA therapeutic community, proposed that the environment of an asylum or hospital could assist in the treatment of the mentally ill by organizing a community or social organization which itself would be healing and toward which everyone is expected to make a contribution. This contrasted with authoritarian mental hospitals in the same way that the US democracy contrasted with Soviet dictatorship. So a lot of times in present day, you see this type of therapeutic community with mental health treatment centers and with substance abuse treatment centers or rehabs, that the group sort of takes care of the group. And, they have certain jobs to do. They have a schedule to follow. They have roles that they play. They take their medication at a certain time. They eat at a certain time. They go to sleep at a certain time. And the idea is that peer-to-peer carefrontation, if you will, or confrontation, is much healthier than this sort of insane asylum or this asylum approach, which is frankly it isolates the individual, and it focuses more on the fact that the person is diseased and not really part of society. So this was sort of a democratic way, if you want to put politics into it, a democratic way of assisting with mental illness. It definitely has its benefits doing that way. It creates more intimacy, it creates a feeling of community. It creates a socialization and friendship. It also creates the fact that you belong to something. And a lot of mental illness is the sense that they're isolated and lonely, or that they're alone. And so you started to see sort of these therapies evolve, even though we weren't there yet, and we're probably still not there, but at least it started to evolve in the right way. Optimism reigned supreme during the 1950s. Psychiatry was once again optimistic. At least one somatic treatment worked really well, ECT. I actually worked in a psychiatric hospital where ECT was extremely prevalent and was used on the depressed patients, and it seemed to have pretty good outcomes. A well thought out theoretical psychodynamic foundation had been effectively established. Here, the Milieu Therapy had emerged. However, it was realized that psychotherapeutic treatment varied greatly by practitioner and was not standardized. And it's still not standardized. There's rehabs out there that are just not, there's no federal guidelines, and frankly, there's no state guidelines that show any consistency. So we're still in the dark ages as far as that goes, and we really do need clinical guidelines to support these patients. Psychotropic medications, this is a big thing. Thorazine was synthesized in the late 1950s and was the first psychoactive drug. Initially, it was developed as an antihistamine. You've heard the term the Thorazine shuffle. This sort of took away from, you know, the psychosis and the acting out and the hallucinations and the auditory and visual hallucinations. It helped to bring together biological and psychodynamic psychiatrists who also found this and other medications useful. Many effective drugs followed and helped move patients into the community, necessitated all sorts of new practitioners, psych nurses, social workers, clinical psychologists. Of these, only psychologists threatened the supremacy of psychiatry, and psychologists' desire to do psychotherapy led to a big fight, as you can imagine. Medicaid and Medicare came on the heels of the civil rights movement, so now we're entering the 60s, the first time that patients' rights were really discussed. Medicaid in 1965 provided a better reimbursement for nursing home care than for mental hospitals. In 1972, Social Security Disability Insurance, SSDI, was expanded to include the mentally disabled, and the Social Security Act was amended to provide coverage for people who didn't qualify for benefits. SSDI and SSI made it still easier for the mentally ill to leave hospitals, since federal payments would allow them to live in the community. The Reagan Era. Reagan reversed 3 decades of federal involvement in the care of the mentally ill in 1981 with the Omnibus Budget Reconciliation Act. Funding was shifted away from the federal government and to the states and communities. Billions of dollars was eventually cut. The Asylum Era at an end. 4 major factors contributed to their closure: the civil rights movement, the development of pharmacology interventions, legislation demanding patients be treated in the least restrictive setting, Reagan era decreases in funding, psychosis or major mental illness becomes no longer a reason to hospitalize someone. So today, with the amount of medication that's out there and the amount of outpatient services that are out there, and just the services in general, asylums are not needed. But the asylums, the way that they were set up, were really never needed. Psychiatric hospitals are still very effective. So that concludes our PowerPoint for this evening. I will take questions and and comments. If anybody has any questions, I'm here. I'm happy to answer any of your questions. One of the things I wanted to point out was we sort of skipped over it, but public opinion always has a major factor in how things come about. And I'm a big fan of One Flew Over the Cuckoo's Nest, both the book and the movie. And Michael Douglas, the actor who produced the movie, he wanted mental illness to be more at the forefront and show what asylums were like, and show that people like R.P. McMurphy, who was probably a sociopath, shouldn't have been lobotomized, and the treatment of the patients. They're treated like children. They were probably over medicated. There was no activity for them to do, nothing to really get excited about. And so it really brought out what was wrong with the mental health system, specifically with asylums, and it brought the public more awareness, and it really made some changes. There was better funding after that, better treatment after that. Most, if not all, the asylums started to close, getting into the 70s and 80s.